Should we announce the opening, sir?
Yeah, please.
Please, sir. Thank you very much. Good afternoon and welcome everyone for joining today's webinar. My name is Dr. Amit Borse and I'm a Group Product Manager with IVA, a division of Emcure Pharmaceuticals Limited. Emcure is a pioneer in the field of gynecology and IVF, and Programming 28 is our scientific theme for the year. I'm very thankful to Dr. Ved Prakash sir, founder of iHERA, to give us an opportunity again to host this event. Sir, IVA will always be there to support all the academic activities. Now, may I hand over the session to you, sir?
Thank you, Dr. Amit. So, good evening, everyone. On behalf of iHERA, I welcome all of you. Just few words about our iHERA. So iHERA is International Human Embryology Research Academy. Our aim is, and it is actually online academic platform related to clinical embryology. Sorry. So our aim is to pass on the most comprehensive knowledge in the field of infertility and ART. It is a free resource on embryology for embryologists, and we believe it is a means for us to make ourselves and everyone to get recognized for their work in the field. This is our team, our advisory board, and our international advisory board, and this is our UA team. So we are doing many more activity related to our embryology field, and we are also planning for new academic courses in next few months. So hopefully it will also be good and joined by many more participants. So thanks to everyone, and I hand over it to Dr. Sanket Dhumal and Dr. Rahul Sen. Dr. Sanket Dhumal is senior embryologist.
Sir, can I share the screen, sir?
Yeah, if you can, you have that?
Yes, sir. Yes, sir.
Yeah, please. So Dr. Rahul Sen is currently working as a chief embryologist, Vasundhara Hospital Limited, Jodhpur, and he is executive member of ACE, Academy of Clinical Embryologists, executive member of ISAR, and he is organizing secretary for Embryology ISAR 2018 held at Jaipur. He is member of ISAR IFS ACE ASHRAE, and he was in the organizing committee member for National Conference IFS 2012, IMS 2013, UA ISAR 2014, and UA POXI 2015. Dr. Sanket Dhumal is senior clinical embryologist, Chama IVF Fertility and Reproductive Medicine Center, Department Option Gynae. He is executive member of Academy of Clinical Embryologists India. He is on editorial board member of journal JBRA, Assisted Reproduction, and he has authored few publications, and to his credit, author and co-author of 3 books chapter. He is a principal investigator for several projects at Chama Medical College. He is a member of ACE and ASHRAE and Indian Science Congress. He is a regular faculty in various national conferences and delivered invited talk, lectures, and conducted multiple advanced workshops in the field of fertility. So over to Sanket.
Thank you so much, sir, for the. So I'll be introducing the first moderator for today's session, Dr. Pranay Ghosh, dear friend of. Currently, is working as a director for Elixir Fertility Center, and he is supposed to be consultant for Double Helix Clinical Cytogenetics and Reproductive Immunology Center. He has done his MBBS and MS from MAMC, and he has done MMed Science Art from University of Nottingham, UK. And he also done diploma in reproductive medicine from University of Kiel, Germany. And he obtained his specialist training in reproductive medicine from NUS Singapore. And he also obtained his fellowship in minimal access surgery. He's an SRA certified clinical embryologist. His special area of interest remain reproductive immunology and oocyte and embryo biology and optimizing strategies for elective single embryo transfer. So over to you, Dr. Pranay.
Thank you so much, Dr. Sanket. So good afternoon, friends. It gives me immense pleasure to welcome you all on this weekend for today's iHERA session on PGT-A. I would like to thank Dr. Ved Prakash sir and the other coordinators of this session, Dr. Sanket Dhumal, Dr. Rahul Sen, for giving me this unique opportunity to moderate this session. We know that aneuploidy and mosaicism levels, they vary variously between different centers, and even amongst the same center, different physicians have different euploidy and mosaicism levels amongst their biopsied embryos. And this variation can be up to the tune of 40 to 80% depending on various factors. So it still remains to be unanimously accepted that PGT-A has improved live birth rates in the intended population, especially in the wake of the recent SART trial. Hence, it would be greatly, immensely helpful if the air around this controversy can be cleared, and if a novel test, which is non-invasive, can be applied to score our embryos, and so that we can do away with the need of laser and invasive testing. So today, for our first talk, we have with us Dr. Carmen Rubio, who indeed needs no introduction to those who are interested in or are practicing PGT. Dr. Carmen Rubio has trained at University of Valencia. She has specialized in cytogenetic studies in human reproduction and has completed her PhD in Valencia in the field of reproductive genetics. Her postdoctoral research includes a sabbatical at the laboratory of Dr. Patricia Hunt and Terry Hasselt, and the work was focused on male and female meiosis and the mechanism underlying human aneuploidy. At present, Dr. Carmen is the head of pre-implantation genetic diagnosis program for chromosomal disorders at Igenomix. And Dr. Carmen is going to talk about optimization of PGT-A program and the need for a non-invasive embryo aneuploidy testing in the culture media. And hopefully by the end of our session, we'll be able to be convinced that we can embrace a new baby, the Embrace test. We'll be able to take a few questions at the end of the session, and delegates are requested to make use of the Q&A window for the queries. So without any further delay, I'd like to call upon Dr. Rubio. Dr. Rubio, the screen is all yours. Welcome.
Okay. Thank you very much, and it's a pleasure to participate in this meeting today. So hello to everybody. I'm going to share my screen. And let me know if you can see the slides properly.
Yes, yes.
Yes? Okay.
Yeah, please.
So I'm going to combine in my talk a little about what is the conventional PGT-A and how to optimize a PGT-A program from the genetics point of view, how we should work in the diagnosis part to get the best results. And for sure, I'm going to talk about the Embrace and the new era of the non-invasive PGT-A. So we all know that there is a high incidence of chromosomal abnormalities in pre-implantation embryos. The blue line represents the incidence in human blastocysts, and after the age of 38 years, this increase is very important, with more than 50% of the embryos that we produce in IVF laboratories being chromosomally abnormal. And we also know that chromosomal abnormalities are an important cause of spontaneous miscarriages, as we can see here in the green line. And again, in patients over 38 years of age, most of the miscarriages are a consequence of a chromosomal abnormalities. So for these reasons, it's very, very important to try to avoid the transfer of embryos carrying chromosomal abnormalities to improve IVF outcomes and to minimize the risk of spontaneous miscarriages. And we know that in the IVF lab, we have many tools for selection of the embryos. We have learned a lot about morphology and the evolution of the embryos up to blastocyst stage, but unfortunately, the quality of the blastocyst is not giving us information of the chromosomal status of the embryos. You can see here two blastocysts with the same morphology, with hatching blastocyst, and the second one has a monosomy for chromosome 12. If we transfer an embryo with a monosomy for a chromosome, the result is going to be a no pregnancy, no implantation. So we know that morphology is not a good predictor of chromosomal abnormalities. Now, in many labs, you have different systems of time lapse to test for morphokinetics. And we know that if we have embryos like this, when we have abnormalities, as you can see in this NGS profile for 4 or 5 chromosomes, if we have many chromosomes that are abnormal in an embryo, this is going to impact embryo development. And in fact, these ones have faster early development in the first stages of cleavage stage, but they are rest before, and many times these chaotic embryos, in more than 90% of the cases, they don't reach blastocyst stage. So this evaluation of this condition, if we are doing blastocyst biopsy, is not really important, because these kind of embryos we are not going to see very frequently in blastocyst stage. And what is really very relevant is these embryos that they have a single aneuploidy. For example, this is an embryo with a trisomy for chromosome 16. If we have a trisomy 16, the result if we transfer this embryo is a miscarriage, as well as if we have trisomies for chromosome 15, 20T, and so on. So if we have a single aneuploidy, the kinetics of the embryos are similar to the kinetics of a normal embryo. That's why morphokinetics can predict some kinds of abnormalities, but the very important ones, the ones that can result in a blastocyst and can implant, the kinetics are similar to euploid embryos. So that's why morphokinetics cannot prevent the transfer of abnormalities, mostly of these single aneuploidies. For this reason, we had to develop PGT-A, and we had to do techniques as the Trophectoderm Biopsy or the free biopsy at cleavage stage. And we were applying this technology mainly for advanced maternal age. This was the first indications. Then we were applying also to couples with a previous pregnancy with a chromosomal abnormalities, in IVF patients with repeated failures, more than 2 previous cycles without pregnancy, in recurrent miscarriage couples, mostly those ones that had miscarriages after IVF treatments, also in severe male factor, that we consider the sperm concentration as the main condition that impairs embryo quality related to the male part. And you know that in some countries, this technology is being applied to good prognosis patients, even in ovum donation, mostly in the States. And the idea of doing in these good prognosis patients to do aneuploidy testing is with the aim of transferring a single embryo with the highest possibilities of resulting in a pregnancy. And what are the main goals? What we want from a PGT-A cycle? Why we indicate a PGT-A cycle to our patients? It's very clear: to improve pregnancy and implantation rates, because we are going to decrease the risk of transferring an abnormal embryo, decrease miscarriages and the risk of abnormal offspring, decrease multiple pregnancies if we go to the strategy of transferring a single blastocyst. And because we choose the best embryo for transfer in our first attempt, we can decrease the time to pregnancy of the treatment and the emotional burden of the couple. And by decreasing the number of transfers needed to achieve a successful pregnancy, we can improve the cost efficiency of the treatment. So this is an overview of the field of PGT-A. And what are the approaches nowadays for PGT-A? The most expanded strategy all around the world is Trophectoderm Biopsy. And then with these 4, 5, 6 cells of the Trophectoderm Biopsy to apply NGS, next generation sequencing, and to have the results in this kind of profiles. Here you can see a monosomy 16. So this is the most spread technology so far. What I'm going to comment in the second part of my talk is what is now here. Like 3 months ago, I was saying this is coming. Now I can say this is here. The non-invasive analysis of the embryonic cell-free DNA secreted to the culture media is now a reality. Now, we can do the analysis of a drop of culture media in which the blastocyst has been secreted small fragments of DNA, and then we can sequence this with special protocols, and we are going to have very reliable results. So we think these are the two strategies that are going to coexist for a time, but we should open the door to the non-invasive because it's coming and the results are very reassuring. So regarding the analysis, the genetic analysis that we are performing, we have really improved the way of diagnosing aneuploidies in the embryos in the last 25 years. We started with day 3 biopsy with a single cell or 2 blastomeres from a day 3 embryo. We were applying fish-proof fluorescent in situ hybridization technology for a limited number of chromosomes. At the beginning, we started with 5 fluorescent proof to identify aneuploidy for 5 chromosomes. Then we started to do different sequential rounds of hybridization, and we were able to analyze until up to 12 chromosomes in a single cell. But again, it was very stressful because we have to do all the analysis in a single cell, and the nucleus can damage after consecutive analysis. But around 2010, everything changed, and we had the possibility to have a biopsy and not to fix the nucleus on a slide. We have the possibility of using this blastomere and to apply molecular techniques to do whole genome amplification and to apply CGH arrays, SNP arrays, or qPCR. So we had the possibility of moving from cytogenetics to molecular techniques. And this changing completely the outcomes. We saw a huge increase in clinical outcomes by analyzing all 24 chromosomes. And we learned that the embryos can have aneuploidies for all of the chromosomes. So it's very important to be able to analyze all chromosomes. And we started with a single cell, with a blastomere, but with the possibility of doing Trophectoderm biopsy with 4 to 8 cells in the biopsy, then we can have more reliable results. And the good thing also of the Trophectoderm biopsy is because this has opened the possibility of analyzing more details of the chromosome constitution of the embryos, because with higher number of cells, higher amount of DNA, and we can gain a little more information from the blastocyst. So we have been able, for example, to understand the mitochondrial content of the embryo and to have tests as mitoscore. We have been able to detect a small segmental aneuploidies that for a small part of the chromosome. And we have been able to determine mosaicism. That is the hot topic in the field of PGT-A, the incidence and the detection of mosaicism. So this has been the improvement that we have done, and it's very clear now that NGS and Trophectoderm biopsy regarding invasive PGT-A are the technologies that should be applied. And this NGS technology has been shown to be very robust also for the analysis of the non-invasive PGT-A, for the analysis of the culture media of the embryos. And let's start with PGT-A and Trophectoderm biopsies. As I mentioned, mosaicism is the hot topic in this field. And the way in which we identify mosaicism and which embryos are normal or not is going to have a high impact in the clinical results. Because if all of our embryos are going to be mosaics or abnormal, this is going to be a disaster for the IVF lab. You are not going to have an embryo for transfer. So we have to be very accurate and we have to be very balanced to have reliable information for the embryos, but not to overdiagnose aneuploidies. And one of the main problems that I have seen in our field in the last 10 years is an overdiagnosis of chromosomal abnormalities in many labs. Because if you don't use the proper technology and if you don't have the proper biopsies, then it's very easy that because of biological reasons or technical reasons, the sequencing profiles that you see, the plots, they start to be very noisy and they can give the appearance of having an aneuploidy, but it's a result of poor quality of the DNA or the biopsy, or that we are not using the proper algorithm for diagnosis of the embryo or the proper platform for NGS analysis. So I'm going to pay special attention to the technical reasons that can impact the incidence of mosaicism, because regarding the biological reasons, there is a very low impact of biological reasons in the incidence of mosaicism. Female age has a very low impact. There is a light decrease of mosaicism with increased female age, but this is because there is an increase in general of whole chromosome aneuploidies. Regarding indications, there is not a clear difference. IVF conditions can impact in the incidence of mosaicism, but only if they are very extreme. Only if you are giving a very strong stimulation protocols to the patients, only if you are not working with the proper incubators. And I think that nowadays, everybody, most of the people has good IVF incubator, proper culture media to keep the embryos in culture for 6 days. So this is important. And sperm has a very low contribution to mosaicism. With lower sperm account, we can have a little higher incidence of mosaicism, but the variability is very low. So biological reasons can have an impact, but are not the main contributors of differences in chromosomal mosaicism among clinics. The main reasons are technical reasons related to the diagnosis and to the way in which the biopsy has been performed. I'm not going to talk about the biopsy. I leave this part for Shanna. I'm going to talk about the diagnosis part, of how to diagnose properly and how to improve the results of the PGT-A. So we really encourage people to work in a really very automatic conditions in the genetic laboratories. It's very important to have a workflow in which we can automate part of the processes to minimize the risk of error. Also, because you know that we are in the era of artificial intelligence, and it's very important to work in very close collaboration with the bioinformatics, because we have thousands of results from our biopsies. So in our service, we have the information of the sequencing data for thousands of embryos. So we can learn from the information of the previous embryos to better diagnose each embryo every day in our laboratories. So we are working a lot in the sense of having our customized algorithms to incorporate the benefits of being able to analyze thousands of embryos. And also we have incorporated validation with cell lines to establish the cutoff values, the thresholds above and below which we have to say that the embryo has a mosaicism. In fact, we published our validation protocol recently. We were using different chromosomes to see how we established the thresholds to call an embryo normal or not. So we have different conditions with all the cells being euploid, 30% of cells aneuploid, 50%, 70%, 100%. And then we were seeing the profiles, how the copy number variations behaves for different chromosomes to establish the proper thresholds for each chromosome. So this is how we have improved our diagnosis, and this is what we call at Igenomix Smart PGT-A. And regarding mosaicism, we consider that it has biological sense to establish the following categories. We are considering an embryo as low mosaic if the incidence of mosaicism is between 30 to 50%, because these embryos can be detected accurately with NGS. If the embryos has less than 30% of aneuploid cells, then all of them are going to be considered euploid. And embryos between 50 to 70% of aneuploid cells, we consider high mosaic degree of aneuploidy. These ones are really risky. You maybe can consider low mosaic degree for transfer, but never high mosaic degree. And embryos with more than 70% of aneuploid cells, we consider them as fully aneuploidy. And in general, using our algorithm and our customized diagnosis, the incidence in general of mosaicism is about 6%. You can have something between 5.5 to 6. This is more or less what we have every time we reanalyze our data. About 4% are going to be low degree mosaics between 30 to 50, and only about 2% are going to be this category, high degree mosaicism. And the good thing is that we developed this tool in our research department, and this tool is applied in all Igenomix labs all around the world. So all Igenomix labs are applying the same technology, so we can have an objective diagnosis, not a subjective diagnosis that can be dependent on the scientist that is doing the diagnosis. And with this, we have a very acceptable incidence of aneuploidies according to maternal age. You can see here that in patients below 35 years of age, the incidence of aneuploidies is below 30%. This is uniform aneuploidies, the dark line. Then if we have other types of aneuploidies that appear in lower percentage, that are high degree mosaicism in pink, low degree mosaicism in gray, and segmentals. So this is the incidence in young patients, and in patients with advanced maternal age, you can see that the incidence of uniform aneuploidies can be higher than 70%, and also we can have segmental abnormalities and other types of abnormalities, but in a very low percentages. When we have all patients, the most important abnormalities are the uniform aneuploidies. And we had the results of a lab, an American lab, that sent an Astra to the SRM 2 years ago, and they were comparing the incidence of euploid embryos with Igenomix and the previous lab that they were working with. And they observed that with Igenomix, the probability of finding a euploid embryo is higher in patients of different group of ages, because as I mentioned, we were trying to balance not to overdiagnose aneuploidies. The no diagnosis rate was lower, so the non-informativity rate in Igenomix is low, and this is very important. And to have this very low no diagnosis rate, the embryology part is very important. So Sana will emphasize in that how to do the biopsy and the tubing is very important to have this low no diagnosis rate. And regarding mosaicism with our system, this lab had about 5% of mosaicism, and with the previous lab, they have close to 17%. That's why we think that it's very important to reliably report mosaicism, not to discard potentially viable embryos. And regarding the clinical outcomes with PGT-A, I'm just showing general data from the American registry published in 2016, just to emphasize the idea that PGT-A is useful for patients at any age. When we are thinking in the outcomes per transfer, we admit that cumulative pregnancy rates are not going to be increased with PGT-A. It's pregnancy rates per transfer. And if you use PGT-A, you can see the dark bar. You can have good implantation rates at every age, and poorer with IVF without PGT-A, mostly in patients of more advanced maternal age. The miscarriage rates can be very stable even in patients of really advanced maternal age with PGT-A. Without PGT-A, miscarriage rates start to increase a lot over 38, 40 years. And at the end, what we want is to have a healthy baby at home. The delivery rates per transfer are very stable per age if we are using PGT-A. So this is the general results of PGT-A in the USA registry. And this is what I wanted to comment about PGT-A. And the last minutes of my talk are going to be related to the non-invasive. So I have advanced some information that we can have fragments of DNA that the embryos secrete during their development in vitro. We have learned in the last years that they are secreting DNA at any stage. When they start to cleavage, they start to secrete DNA, but the amount of DNA that we can have in the drop, in the medium drop, is much higher when we have ablastosis, and with ablastosis with a good number of cells. For this reason, we collect the media on day 6, because we want to be sure that the blastocyst has a good number of cells. If not, if we collect the media in the previous stages, as you will see in the slides, the consistency of the results is lower. So the EMBRACE and our non-invasive PGT-A approach is based in the analysis of culture media collected on day 6 or day 7, in case the embryos are very slow. And then we can analyze this drug with NGS. This strategy has been solved by different groups. Many groups were trying to have a non-invasive strategy. And when we were evaluating the benefits of this technology or the possibilities, most of the studies, we were comparing the results of the culture media with the Trophectoderm biopsy. And you can see here the variability in the concordance rates by different groups. And from this slide, I would like to emphasize that they said they were using non-invasive technologies, but in all of these studies, a previous manipulation of the embryo has been performed. A day 3 biopsy, a day 3 assisted hatching for the biopsy, polar body biopsy, assisted hatching on day 3 plus vitrification, blastocyst collapse to obtain the blastocellic fluid, plus the media. So in all these cases, they were not really non-invasive strategy because they were manipulating the embryos in some way. And the purpose of our team was to try to see if we can have concordance rates as high as 80–85% without touching the embryos during the development in vitro. We started our research more than 5 years ago. We had our first publication in 2018 that was a proof of concept in human reproduction. In 2019, we did a pilot study in which we were fixing the conditions for the protocol to have the better results. And just recently, we published in the American Journal of Obstetrics and Gynecology an extensive multi-center study to see the possibility of reproducing these technologies among different centers all around the world. So let's start by the first study. In our first study, we were able to see that there were higher concentrations of DNA in the media in contact with the embryo compared to clean drops of media without contact with the embryos. We saw also that euploid and aneuploid embryos release the same amount of DNA. That's why we don't think that the aneuploid embryos secrete DNA as a way of self-correction. No, all of them secrete similar concentrations. And just for curiosity, we observed similar concentrations of DNA in male and female samples. And regarding the day of media collection, we started to see that the concentration of DNA was higher on day 6 and on day 7 compared to day 5. We started to observe this in this study in which we were measuring concentrations before amplification and after amplification. And our results has been supported by this recent publication by Meyers et al., in which they also measure concentrations before amplification at different days. And they observe that if they collect the media on day 6 and day 7, they have significantly better results compared to day 5. And coming back to this, our first study that was the proof of concept, in this study, we were collecting the media on day 5, we were working with embryoscope, and we observed low concordance rate, just 30%, with 60% of cases with partial or full contamination. So we said, this is not working, we should modify what we have been doing in the IVF laboratory, and also we need to see how to improve the informativity and how to work in the NGS laboratory. In our second paper in the fertility sterility, we changed the tips we give to the IVF laboratories to culture the embryos, and also we modify our NGS protocol, and you will see how the results were. We were establishing also the best timing for media collection, and you can see how on day 6, the embryos have higher informativity rate and the concordance rate was 84% compared to day 5. Day 5, with our modified conditions, was much better than in our first publication, but the concordance rate was 63%, still not good enough. Now, with day 6, we consider that we can have consistent results. And here you have examples of how you can see the profiles. On top, you have a Trophectoderm biopsy of a normal male embryo, and here you have the media. So you can see how the results are very similar. you cannot distinguish which one is the biopsy, which one is the media. So the results, if you collect the media on day 6, and if you work in the IVF protocol, following strictly our indications, this is very important. If you work in collaboration with us for this, we will need to validate your IVF lab, and we will teach you how to work in the proper conditions. Here you can see the concordance for aneuploidy embryos, and this is how it works. You can see discordance also in some cases, and this is when we have contamination. Here you have an abnormality in the Trophectoderm biopsy, but in the media everything is normal female. And this is one of the very important things to pay attention to have a good embrace or non-invasive PGT-A in your center. Contamination can come from the cumulus cells that surround the oocyte, so we should remove them very carefully, and we have to do some extra washes during embryo development to minimize the carryover of these cells. We have to work in very good conditions to avoid contamination from the female and male embryologists, because we can contaminate with our DNA the culture media, and this is important to have in mind. Okay, so what is our experience regarding the, I don't know. Okay, I hope you can see my arrow properly. So also it's very important to be able to understand the clinical impact of these results. So in this study in fertility sterility, we were able to follow up the results of 29 single embryo transfers, that all of them were performed with a euploid trophectoderm biopsy and blinded results for the media. We knew in the genetic lab the results for the media, but the IVF lab only knew the results for the trophectoderm biopsy. And after the transfer and after the clinical follow-up of the cases, we were able to group the results into parts. In one part, the cases in which the trophectoderm biopsy and the media was normal, and then here you have very good clinical pregnancy rates, 52.9, and very low miscarriage, it was like 0, with an impressive ongoing implantation rate. And if we go to the group in which the tropho was euploid but the media was abnormal, then pregnancy rates were lower and ongoing implantation rates were much lower because of the incidence of miscarriage. These are very preliminary data because the numbers are very low, but it was suggesting us that the analysis of the media will work nicely to try to minimize the risk of transferring abnormal embryos and to avoid miscarriages. And with these results, we designed the big study in which we included 8 centers all around the world. You can see different continents. And these are the results of the interim analysis that we published recently. The final data will include more than 3,000 embryos, and we hope to finish this study by mid-2021. So when we were collecting this data from 1,301 blastocysts, we compared the results with the trophectoderm biopsy and also in a small group of embryos with the inner cell mass. And our concordance rate can be as high as 86.3%. The average is 78.2, but you can see here in the table that at least 4 centers had concordance rate above 80%. And we think this is really something affordable, that following our protocol, you can have this concordance rate higher than 80% very easily. And we were trying to understand different factors that could impact the incidence of the concordance. We observed higher concordance rate with maternal age, but it was a light significant increase. And we confirmed that different incubators and culture medias were not affecting the results. And what was very, very reassuring was the possibility to compare the results of the media with the inner cell mass, at least in 64 informative samples. And you can see here how the informativity rate with the inner cell mass was 84.4%, very similar of the media with the trophectoderm. We believe that the media has DNA that comes from cells of the inner cell mass and the trophectoderm from both, but we will need to confirm this with our basic studies. So these are the publications we have, and now we have translated this to a clinical application, to a clinical test. that we have called it Embrace, embryo analysis of the culture environment. And for each embryo that we are analyzing, we are giving this embryo the probability to correspond to a euploid blastocyst. This is what we call a euploidy score, the probability that this media has to correspond to a euploid blastocyst. And the idea of this test is to offer a prioritization system. So if you have all the embryos of the patient, it's not to deselect embryos, it's just to say, if I have 4 embryos, for example, which one is better to transfer first to have the best possibilities? And this is the way in which we are offering the information. The idea is to choose the embryos with higher probabilities for the first transfer. And because of this could be applicable for every IVF patient, because any IVF patient can benefit for a better selection. The same way that we use morphokinetics to have additional information of the embryo to increase the probability of pregnancy in the first transfer, we can incorporate the analysis of the media that is non-invasive to choose better the embryo for transfer for any IVF patient. And the final slides of my presentation are related to the fact that how important is to work properly in the IVF lab and to do a validation before starting to apply the test. So the idea is to test the results with your PGT-A cases. So to do a small concordance study with every IVF clinic that wanted to be enrolled in the project. So in some cases, we can compare the results of the media with the Trophectoderm biopsy, or we can compare the results of the media with the full blastocyst if we are using discarded blastocysts that are very slow and they are not used for the IVF cycle. And you can see that this is an example of the centers we have validated in Spain, how the concordance rate that they have achieved in many cases are very close to 85, 88, 90%. So the results are very good in the clinics. The average is 83.9. We have learned also that if you have embryoscope, the embryoscope in which you can grow the embryos individually, then we can have also very good results, 85% concordance. So it's not only conventional incubators, we can work also with any time lapse incubator if the embryos are cultured individually, because you can imagine that the embryos need to have separate media to analyze individually. So these are the results that we are having now that we are applying the technology. We have had several pregnancies so far. We have done more than 30 clinical cases so far in Spain, and we have pregnancies in Spain, in Austria. We have pregnancies also in Brazil. So now we are doing the follow-up, and this is the state of the art today for Embrace. So finally, I would like to thank first my mentor and the supporter of this project, Professor Carlos Simon, that you all know, my nice team working in developing this test, Luis, Carmen, and Lucia in Spain, the clinical studies team that has been working in the monitoring of all the data in each IVF center, because there has been a very rigorous monitoring. And we are doing basic studies in collaboration with Professor Nicolas Placha to understand the dynamics of this DNA and to try to see where this DNA comes from. And the last slide is just to thank all my colleagues at Igenomix all around the world, because they have been supporting these studies and they have been participating with their experience also in the different studies. And of course, a special thanks to the team in Delhi, India. Thank you very much for your attention.
Thank you so much, Dr. Rubio. That was indeed a very informative session. And we do have some questions coming in. And one of the participants wants to know whether there's any means of increasing the yield of the DNA. I believe you mentioned that if we culture the embryos till day 6 or day 7, we will be getting almost 100% informativity. So does that mean if we are culturing embryos till day 6 or day 7, there are no calls, you are able to get 100% results in all these cases and there is no need for reanalysis?
No. The informativity rate now that we have for the Embrace is around 90%. What you see 100% was in the pilot study with only 108 samples. In the big study with 1,301 samples, the informativity rate is about 90%. And it's about 90% mostly because in few embryos, if they are very slow on day 6, we had low DNA amount. So if we don't have enough DNA in about 3–4% of the cases, if the embryos are slow, we don't have enough DNA. So I think we can overcome this. If we have very slow embryos on day 6, it's better to keep them until day 7 and to collect the media on day 7 to try to see if we can get more DNA. This will be one solution for this. And the other situation in which we have non-information is in cases in which we realize that maybe the preservation of the DNA have not been proper during the procedure. So we work with the IVF centers to improve the quality of the storage and the because it needs to be frozen, it needs to be kept in frozen conditions until shipping, and the shipment should be performed in proper conditions. So this 10% of non-informativity is mostly related to this, and we are learning how to minimize it.
So, corollary of the question, how do we deal with the non-information? Because in cases of embryos, you can always go back to the embryo and rebiopsy, but with spent culture media, I think after we give you a sample, we would end up discarding the rest of it. There would be no spent culture media to come back to in case of those 10% cases.
You can do biopsy. In these cases, you can rescue the non-informative one doing the biopsy. You can thaw the embryo and you can do the biopsy and vitrify again. As for the PGT-A in which you are doing rebiopsies, you can do this without any problem. But also the situation is different for the non-invasive compared to the PGT-A, because with the PGT-A, you want to classify the embryos as good or bad. So you have this dichotomy and you discard all the abnormal embryos. Most of the couples that will join to the non-invasive is because they don't want to discard any embryos. They just want to start first the embryo with higher possibilities, second by the second one. And in this sense, the non-informative embryos, we are giving them a risk according to the age of the patient. So if the cycle is being performed in a patient with 35 years of age, the non-informative embryos are going to have the risk of aneuploidy according to the age. And we consider this for the prioritization of the embryos. So we are giving you some information also for the non-informative. We are not telling you what are the results, but the risk according to the age. So according to the age in general, a non-informative embryo can have maybe 50% of risk of aneuploidy. But you have other embryos in this patient. And if you have a euploid embryo, then the probability of being good is higher. But if you have an embryo, for example, in which the media has a trisomy 21, then this embryo should be discarded first than the one that is non-informative. So we are going to give you a gradation of the risk, even if the embryo is non-informative. So you can decide to go for a biopsy of this non-informative embryo, or you can consider the priority, the rank that we are delivering in the report to decide whether to transfer or not. And I think everything is going to be the counseling to the couple is going to be related to the age of the couple and the previous fertility story of the couple.
Right. There's one more question that I'd want to ask. You would believe that, due to the apoptosis and shedding of the cell-free DNA, it would be higher in amount into the blastocele fluid rather than the spent culture media, but it seems it is converse. We find higher cell-free DNA in the spent culture media rather than the blastocele fluid. So can you comment, would it be any added advantage if we were to sample this blastocele fluid along with the cell-free DNA in the culture media?
Okay, I would not recommend to do the blastocentesis. I would not recommend to collapse the blastocyst because it's not needed. We have the same concordance rates by testing only the media compared to testing the media plus the microfluidic, the blastocelic fluid that is inside the embryo. If you think the volume of the blastocellular fluid is very, very, very small. It's very, very small, and I have been working with this, and it's very variable among blastocysts. In some blastocysts, you cannot aspirate more than 1 microliter, even less, so it's very variable among blastocysts. And the culture media is very stable and very consistent. So the contribution of the blastocellular fluid to the analysis of the full media, I think, is negligible. I think makes no sense to do this extra manipulation of the blastocysts. And also one of the aims of the non-invasive is the possibility to be applied in small IVF centers in which you don't need to have a biopsy or a system just to do this blastosynthesis. So the idea is to have it the easiest as possible and the most physiological as possible for the blastocyst.
And one last question, Dr. Carmen. I think this embrace would necessitate a change in how the clinic cultures their embryos. There might be some clinics who would be doing group culture. They would be doing, some clinics would be doing micro droplet group culture. And I'm pretty sure that not all of the embryologists would be very happy culturing all their good 4A blastocysts, which were good blastocysts on day 5, and let them be till day 6. So I think, how do you manage, because you are converting a lot of your clinics to uptake this new technology, how do you deal with these embryologists? Because as an embryologist, it is very difficult to let a 4A, 5A on a day 5, let it be in the culture for another couple of days. So do you face any reluctance, or is it just?
Okay. Yeah, this was our first worry, because I am also an embryologist. My background is also an embryologist. So this was our main worry. And that's why in our first study, we started collecting the media on day 5, but we realized it didn't work. So that's why in the second study, we were working with a clinic in which they were doing biopsies in the regular program on day 5 and day 6. And the first thing was to compare how were the pregnancy rates when they were transferring euploid embryos on day 6, when they did the biopsy on day 6, comparing when they were transferring the embryos on day 5, and the pregnancy rates were similar. So in a regular PGT-A program, if you are doing the biopsy and you transfer a euploid embryo, it should be euploid. The pregnancy rates are going to be the same. If you are not doing chromosomal analysis, you can have better results on day 5. But once you do the chromosomal analysis of the embryo, if the embryo is euploid on day 6, it's going to have the same pregnancy rate. And regarding the development of the embryos, if you are not doing previous assisted hatching on day 3 for the biopsy, so if you are not touching the embryo at all and you leave it growing, on day 6, the incidence of hatching is going to be very low. It's going to be about 10%. We can discuss special cases, but in fact, now we have been talking with more than 100 clinics all around the world. And the point is that most of the embryologists feel scared to keep the embryos, the good embryos on day 5, to keep them one more day. But the truth is, when they start with the validations, they say, wow, at the end, if the embryo is nice on day 5, it's going to be nice on day 6. So they are not now so extra worried about this. And regarding different culture strategies in different labs, we talk directly with each IVF lab, and we can adapt our protocol to each IVF lab in a way. So we have some requisites that we cannot modify because they are very important. For example, to collect the media day 6 in the morning, you can collect very early in the morning of day 6, but should be on day 6. This is a fixed requisite. But regarding the previous steps, we can just talk with the IVF lab, understand the way of working, and trying to find the easiest way of implementing the technology. We were very fixed in the study we published because we wanted to have the very similar conditions among the labs. But now in the clinical application, we are like tailoring a little the protocol for each lab by covering the minimal requirements.
Excellent. Thank you so much, Dr. Rubio. We have finished well in time, and I think most of us will be able to embrace. I'm pretty sure you have heard it before as well. So,
Thank you.
It's a nice ring to it. So thank you again. And I'd like to hand over the screen to our coordinators, Dr. Sanket, for the next session. And can I have the moderator for the next session, Dr. Sarpreet, sir, please? Thank you.
Thank you, Pranay.
Dr. Akash, you're there?
Yeah, I'm
Yeah, please introduce Dr. Sarapjit Singh.
It was a really wonderful talk and quite some clarifications about continuing on day 5 to day 6 and taking forward the session for the second talk of the session. It's my pleasure to introduce Dr. Sarapjit Singh. He is MD AIMS in anatomy. He's a senior consultant and chief embryologist at Artemis Health Institute. He's a IFS and STA certified senior clinical embryologist. He's a convener IFS SIG from 2018-2020 and was awarded for the best convener for SIG at Fertivision. He has also been awarded Champions of ISAR Award at ISAR Conference 2020 and is the convener for IFS SIG Applied Genetics 2020-2022. His key area of interest are cryobiology and male infertility. And over to you, Dr. Sarapjit.
Yeah, thank you, Akash, for the kind words. First of all, I would like to thank iHERA for giving me the opportunity to moderate this session. Wonderful, very lucid. So let's now review what actually determines the success or failure of PGT results. That is how well the biopsy is done. Till the time we're doing the biopsy, we have to focus on biopsy. Once we embrace the embrace technology, we can, forget biopsy. But in those 10% cases, we still have to do biopsy. So Dr. Shana Sameer Dange, she is going to speak on what procedures are important in embryo biopsy, what procedures we should be careful about, where we can go wrong, and what precautions should we take to avoid these common mistakes. So now I welcome Dr. Shana Sameer Dange. She is a MSc with PGT in IVF and reproductive medicine, German UAE, LQMS from Clinical Laboratory and Standard Institute of USA and WHO. And she's an embryologist with more than 6 years of experience in the field. And she has worked as a quality specialist at Igenomix, covering Middle East and India. She's going to speak on trophectoderm biopsy and tubing techniques, tips and tricks, lab preparation, and requirement for PGT-A. And she's going to speak an embryologist point of view. Over to you, Dr. Shana. You have to unmute yourself. Sana, you have to unmute yourself. Yeah.
Oh, sorry. Thanks for the introduction. I will be sharing my screen. Let me know if you are able to see.
Yeah, we can see now.
Okay. So let me start with the introduction to, just a second. Just a minute. Okay. My screen is visible?
Yeah.
Okay. So let me start with...
Sorry for the interruption. Dr. Sana, can you please put it in the slideshow?
Dr. Sana, can you put it in the slideshow?
Yes, yes.
Ma'am, also start your video if you can.
Just a minute. I'm having some technical issues. Is it okay now?
Sana, you have the slide show button at the bottom. Just see at the bottom, just bottom, there is a kind of icon. Just click on that.
Yeah, to your right, yeah.
No, come back, escape. Yeah, other one, yes.
I think it's fine now. Thank you.
Yes.
Ma'am, please start your video.
Yes. Okay. So basically, let me introduce first, like, what is embryo biopsy? Just for the analysis of embryo or chromosomal or genetical euploidy status of embryo, you will be removing a part of a blastocyst or the cleavage stage embryo, and you will be doing analysis, and it is nothing but called as embryo biopsy. So as indications, already Dr. Carmen explained well in her presentation, like advanced maternal age can be an indication for biopsy, recurring pregnancy loss, which is more than 2 miscarriages, repetitive implantation failures, which is more than 2 failed IVF cycles. Severe male factor can be one reason, prior pregnancy or child, which is chromosomally abnormal. And So, and also for, just a second. Okay. So as a laboratory, what are the things that you require for performing an embryo biopsy? Firstly, you need to have a very well equipped system of micromanipulation. The joystick and the micromanipulating controls will help you for the coarse and fine movements of the needles. You require a very good precision controlled biopsy needle and holding precision. Then you require a very good laser system. There are many laser systems available in the market. The one you can see on the screen is from Hamilton Lycos. You will be also requiring a good biopsy media, which is supplemented with HEPAs. I am explaining this media for trophectoderm biopsies. For cleavage stage biopsy, there is different requirement with the media. So today my presentation will be completely focused on the trophectoderm biopsy. The needles that you will be used for the biopsy is also plays a very crucial role. The selection of proper needles. For trophectoderm biopsy, we recommend using a flat small needle depending upon the size of the embryo. There are some references given on the slide. You will also require a heated stage, which is to maintain the temperature when the dish is outside for the biopsy and to control the temperature requirement for the embryo during the biopsy. Okay. Next requirement you have for trophectoderm biopsy is preparation from the like having denuding pipettes. The size requirement goes from 100 to 150 microliter of size. Then automatic pipettes, micro tips, which we recommend using RNA DNA pyrogen free so as to avoid any kind of DNA contamination. Will be requiring mineral oil and the aliquots of media which you have already incubated a day prior upon your routine culture system. Culture dish of about 60 size, the similar size that you might use for ICSI will be fine. Then there comes a step where you will be preparing a dish for the biopsy. So during the preparation of the dish, you will be requiring about 20 microliter per embryo drops for the biopsy. Upon the maximum, you can go up to 3 or 4 drops in one dish, and you can overlay it with the oil, that is 4 ml to 5 ml as per the requirement. Then you will require additional 2 drops maybe for washing the pipette, as if you have done the alignment in the beginning and you don't want to change the biopsy pipette again and do the alignment for another embryo, you can use the same needle. But the step here important is when you're performing the biopsy on one embryo, you need to use the washing drops to wash the biopsy needle so as to remove any debris or cell remains in the needle, and it will so that it doesn't interfere in the biopsy or the results of another embryo. So this is all pre-preparation that you will be doing for the biopsy. Next, I am explaining which embryo to be selected for the embryo biopsy and which shouldn't be biopsied. So less than expansion grade 3 according to the Gardner system should not be used for the biopsy. Preferably go for the more expanded good embryos with hatching trophectoderm cells, so it is easy for the biopsy. Next, the embryoblastosis grade of C or D trophectoderm should not be used as per Gardner's criteria classification. Bad quality trophectoderm cells, like which are degraded or granulated, or cells where you are not able to see a visible nucleus, avoid doing biopsy on such embryos because they are going to lead to poor results on analysis and it is a waste of embryo. Next is blastocyst development. It should be avoided to biopsy on early day 5 blastocyst because there is chance of you removing very less number of cells for the analysis, which again will not give you very good results because there is not enough DNA with few cells, and there is also higher risk of using more laser shots and also maybe damaging the ICM. In these cases, it is preferably recommended to wait for day 6 for the embryo to be more expanded and to be used for the biopsy. The number of cells that are recommended to do the biopsy is 5 to 8 cells of the trophectoderm cells to give a better result. Okay, so that for the trophectoderm biopsy, there are like 2 techniques which are most popularly known, which is pulling technique and the flicking technique. The pulling technique is mostly used for an early hatching embryos or the cell or an embryo which has been assisted hatching on the day 3, so that you have some cells on day 5 coming out from those that part of the assisted hatched zona pellucida. Or you can wait for the natural hatching of the embryo on day 5 and then proceed for the biopsy. I will be playing a video. Please let me know if you can see this. So in this Firstly, when you have an embryo on day 5, on the inverted microscope, rotate the embryo until you can see the ICM of the embryo. Then with the holding pipette, hold the embryo from the ICM part like to the side, and the biopsy pipette should be opposite, far away from the ICM. The trophectoderm cells, with the biopsy pipette, try to just touch the trophectoderm cells which are herniating and see if there is any aspiration movement, and if there is no, then apply a slight aspiration, and with the help of laser system you can apply like minimum 5 laser shots, few laser shots to make it easy for the biopsy. Try aspirating the cells. As you can see in the video, apply some laser shots on the trophectoderm cell junctions, and with a mechanical movement try to make the biopsy needle and the holding pipette apart from each other with applying the mechanical movement as well as the laser shots. The detachment of the trophectoderm cells from the embryo will be done easily. As you can see, apply the laser shots on the junction of the trophectoderm so that you do not degenerate the nucleus of the cells that you have biopsied. And if the laser shots are not properly applied, you will end up having no DNA results because the DNA is already damaged due to the laser. This is all about the pulling technique. Next, I will be explaining you is the technique of flicking method. This technique can be applied to an embryo which has expanded more and has more number of trophectoderm cells hatching, and also for an embryo which is completely hatched, which I will be showing in another video. For the same, once the embryo is ready, see under the inverted microscope, try to focus it properly because the focus is important. It will make the biopsy easier and not damaging the embryo. Hold the embryo with the holding pipette, and with the biopsy needle, try to aspirate the cells. If required, you can again apply some laser shots so that the blastocyst collapses and more number of cells can be aspirated in the biopsy needle. So once you have a proper hold of the trophectoderm cells, apply some laser shots on the trophectoderm junctions, and then apply a mechanical friction between the holding pipette and the biopsy needle, and just do a flicking movement with which the cells will be cut from the blastocyst, and you will have the trophectoderm cells for the analysis. The similar The similar method will be used for a completely hatched blastocyst. In this system, if required, you can hold with the holding pipette, or just without holding, it can also be done. Just aspirate few cells of trophectoderm in the biopsy pipette, try to aspirate, and then the same flicking moment as you did as seen in the previous video, do the same. Place it on top of the holding pipette and do the friction, or with the help of the joystick, move the holding pipette down and cut the cells. So this is where the biopsy is performed and the embryo does not collapse much, and you can vitrify this as well. So there are some difficulties you can face during the trophectoderm biopsies. First is fully expanded blastocyst with no or few cells hatching. When you have a fully expanded blastocyst and there are no cells hatching, you can do assisted hatching on the same day for the embryo, and you can aspirate the cell and do the biopsy. If it's having more cells, you can again put some laser shots to collapse the embryo and aspirate more number of trophectoderm cells. Second is cell loss during the biopsy as a result of wrong biopsy pipette. The selection of the right biopsy pipette is very important, as well as the holding pipette. The size or the diameter of the holding pipette should be big enough so that when you hold the embryo, it does not move when you are doing the biopsy. Secondly, when the size of the biopsy pipette is important, because when you are aspirating the cells, and if the size is not proper, you might end up aspirating the trophectoderm cells, which will travel through the tube, and the cells will be degraded or disaggregated, and for you to do the tubing procedure or to do the analysis will be difficult. You might lose the cell and the DNA due to not selecting a proper biopsy or the holding needle. Nextly, if a fully hatched on embryo or embryo without zona pellucida, to do the vitrification. This is another difficult step. You need to be a very well experienced with the vitrification techniques for the biopsy or an embryo. While I can provide you a tip, like when you are doing a vitrification for a completely hatched embryo, try not to aspirate the complete media from the cryolog or whatever you are using for vitrification. Keep little VS solution so that it does not like it does not stick to the cryo loop, or when you are thawing it will be easy and it will not be degraded. The next is ICM in the poor location extruded through the hole. Like when you these scenarios are mostly can happen when you are doing an assisted hatching on day 3, and to have like some cells herniating on day 5 for the biopsy, you might end up like ICM hatching from the zona pellucida, and the biopsy will be difficult. So here what you can do is you can do laser assisted hatching to the opposite side of the embryo, and then try to do the biopsy by aspirating the cells of trophectoderm cell. As you can see in the video, this embryo is not very expanded, but because the ICM is hatching from the other side, the biopsy is performed from the opposite by doing an assisted hatching on the opposite side. A flicking technique can be used for any kind of embryo biopsy if you are more comfortable. The next is when trophectoderm cells become sticky or fibrous. Sometimes when you're doing the biopsy, the situation can be like the trophectoderm cells tend to, because it's sticky, it might get stuck into the biopsy pipette. Just a small jerk on the biopsy micro pipette will help you release the cell from the needle, and you can then use it for the tubing. Also, maybe denudation. Proper technique of denudation will help you remove the trophectoderm cells that might stuck to the bottom of the dish. Next is biopsied cell loss during tubing. This I will be explaining in my further slide, which is about tubing, like how the scenarios can be avoided losing the cell during the loadings of embryo. Tubing, once the biopsy is done, the next step that you will be doing is loading these cells in a PCR tube so as to send it to a genetic lab for analysis. So for this, you will be requiring a dish, a Petri dish, in which you will, as an Igenomix, they will be providing you a kit which will be equipped with washing solution, a mini cooler rack with pre-filled PCR tubes with loading solution, which is about 2.5 to 3 microliter. Once you have received this, take out the mini cooler rack, take out the tubes. Okay, once you have this, take out the tubes, label it properly with the patient initials and embryo number. Then prepare a dish according to the number of embryos biopsied. Prepare 4 drops per embryo, and which will be size of 10 microliter of the washing solution provided provided in the kit. You will require the denuding pipette of size from 100 to 130 micrometer. You can adjust the volume of the stripper to 1 microliter so as to avoid aspirating too much media during the loading procedure, because the final volume that you need in the biopsy in the PCR tube is maximum to 4 microliter, so as to not dilute much and have a good result. So once you have prepared the dish, you have selected the embryo, you have labeled the, you have biopsied the embryo, you have labeled the PCR tube, select the PCR, particularly specific respective labeled PCR tube. Then you have to wash the biopsy samples from one drop to another drop from another. This step is to be performed in 3 washings. Then once it is washed, take the cell and load it in the, as you can see in the image, load it in the PCR tube at the bottom of the cell, bottom of the tube. For this, when you are loading, you need to be more focused through the microscope. You should be able to see the tip of the needle, the denuding pipette, when you are releasing the cells. The cell, you should see the movement of cell going through the denuding pipette to the PCR tube. If you're not sure like the cell has been gone or not, the remaining amount of media you can check in the fourth drop of the dish to see if the cell has been returned, and then you can, if the cell is returned, you repeat the procedure of the washing and then loading the PCR tube. And if you cannot see the cell return, then again to perform another double check, what you can do is focus the PCR microscope to the bottom of the PCR tube in which you have loaded the cell. Try to adjust the focus until you see the cell in the PCR tube. So this few things can be done. Also, the for trophectoderm cells, aspiration is a very important part where you have to make sure that you don't aspirate the cells too fast or release it too fast, so that the cells don't get disaggregated. Also, in some scenario, if the cells are disaggregated, you can collect as many media along with the cells and try to release in the PCR tube, so that you might have results. So this is all about tubing. Once the tubing is done, you will put the PCR tube back into the mini cooler rack and put it in the deep freezer until the shipment. Okay. Okay, next is packing and shipment. This is on the image, you can see the kit that Igenomix provides. It has 3 mini cooler gel racks and 3 gel packs, red gel packs, 1 mini cooler rack. You will have a biopsy sheet and TRF and the consent. TRF filling the forms is also very important, so as to avoid any confusion when you are sending the samples. All the mandatory fields in the biopsy sheet and the TRF should be filled. The consent should be signed by the patient, and as you have received the kit in the beginning, try to pack it in the same way when you are sending the kit. Do all these procedures with gloves. Also, one important thing I missed to explain in the previous slide is, when you are doing biopsy, you will be performing it under the controlled temperature, that is 37 degrees Celsius as per the embryo. But for tubing, you will be requiring at a room temperature. Personal protective equipment is very important when you are performing the tubing or the biopsy, so as to avoid external DNA contamination from your side into the sample. Also, perform the tubing on a cold surface laminar hood. Try to clean the laminar hood prior to performing the tubing procedure, so there is no contamination in the results. Once you have done the packing and shipment, you can send it to the lab. You can call Igenomix, send it to the lab. There are some disadvantages for trophectoderm biopsies is you require a very stable culture system when you are performing biopsy for trophectoderm, and also you need to have a very good blastocyst rate. You must have a good equipment, incubators, microscopes, optics, micromanipulators, laser systems, etc. Also, there are some clinics like who won't have a laser system in their clinic or lab, so they can also opt for a PGT-A specialist who comes to their lab and carries their own laser system, so as to avoid investing in the laser. Also, the embryologist, you need a very higher skills for performing biopsies. No fresh cycle transfers can be done in majority of the cases, and cost of vitrification is more. You need a very well established cryopreservation program so as to not lose the embryo post biopsy vitrification and thawing. Next is importance of the biopsy. Again, it will improve the implantation rate, decrease the miscarriage rate, decrease the risk of having an abnormal offspring, time to the pregnancy, cost efficiency, and emotional burden. The time to the pregnancy is reduced, cost is reduced, and emotional burden to the patient is reduced. Blastocyst embryos are more robust than cleavage stage embryos, as you have more number of cells for analysis as compared to the cleavage stage. They also have higher implantation potential, which aid in single embryo transfer. Then fewer number of embryos to be biopsied as comparing to the cleavage stage, and analysis of more number of cells, which increases the accuracy and sensitivity, and high presence of euploid embryos. Okay, as an embryology good practice, you need a good sample. Good samples will give you consistent results. Performing all the steps carefully, properly with good technique will give you a better result. Avoiding biopsy on a poor quality embryos, because it will be a loss of money, and you will be giving a fake hopes for the patient, and it will decrease the success rate of your clinic. So what is important when you have a patient for which you have to go for a PGT-A or genetic analysis? If required, you provide genetic counseling to the patient so that you know which exactly test is to be recommended for the patient. If it's monogenic disease or translocation or a basic chromosomal aneuploidy, then you have to perform the IVF cycle, do embryo assessment, properly grade the embryo, do biopsies on a good grade embryos, collect the sample, send it to a genetic lab. The genetic lab will perform the analysis of the sample. The results will be interpreted in the reports. Then the counseling, if required for the clinic, will be done to explain the results. The clinic will then explain these reports to the patient, give them a better option of embryo transfer, and it will end up having a good result for the patient as well as for the clinic. So in my conclusion, I would just say trophectoderm biopsy techniques require practice, micromanipulation systems, laser systems, good cryopreservation, and it can be used for doing genetic analysis for monogenic disease or chromosomal abnormality of translocation or just any other chromosomal aneuploidy. And the key factor for biopsy of trophectoderm is all embryos are different. They can act differently depending upon their expansion grade, their quality, and every perform biopsy, you need to keep practicing, not just biopsy, the tubing part as well, and follow all the necessary steps. So here I will end my presentation. Thank you.
Yeah, thank you, Sana, for that nice presentation. We have some questions for you.
Okay.
Many embryologists in the audience, they want you to highlight the steps in trophectoderm biopsy. Just recap, kind of. Sana, okay.
Can you see my screen?
Yeah.
Okay. Any specific biopsy technique they want me to focus on?
They want you to, highlight the steps right from the first step to the time, tubing is done and sample is dispatched.
Okay. So the first technique is pulling technique and the second one is flicking technique. In pulling technique, if you have done assisted hatching on the day 3, you will have some cells herniating from the zona pellucida on the day 5, which you can use for biopsy. Firstly, you need to focus the embryo under the inverted microscope so that you can see the ICM. And according to the ICM, you will hold the embryo with the holding pipette, and with the biopsy needle, or the biopsy should be performed far away from the ICM. It should not damage the ICM when you are performing the biopsy. So for the pulling method, what you can do is when you have focused the embryo, you have properly hold the embryo in place, and you have the cells herniating, try to aspirate with slight pressure. Pressure is very important when you are aspirating the hatched trophectoderm cells. Aspirate the at least 5 to 8 cells in the needle. Then if required, you can apply some laser shots on the junctions of the trophectoderm cells. Then with the mechanical movement of holding pipette and the biopsy pipette, both the pipettes needs to be moved apart from each other, so there is a tension created between the cells of the trophectoderm and the embryos, the blastocysts. And like along with this mechanical movement, you can again apply the laser shot so that it is more easy for the separation of the cells from the embryo. This is what is all about pulling. I'll just show the video once again. Here you can see the aspiration of the cells. Laser shots should be done in between the cell junctions. You should also have a very good focus when you are doing the biopsy so that you don't damage the DNA of the cell. Sorry, this is regarding the flicking method. Flicking method, I will explain. Like when you're doing flicking, you need to focus the embryo, the ICM, hold it properly. With the biopsy needle, aspirate the cell, put some laser shots if required. The holding pipette should be firm. You should not move the holding pipette when you're doing the flicking method. With the biopsy needle, when you have aspirated the cell, release the holding pipette if required, and the biopsy needle should be placed on the top of the holding pipette, and then a friction should be done, like just move the holding pipette or try to like pull with the joystick against the holding pipette so that the cells can be cut through try to move the biopsy pipette so that the cells can be cut down from the embryo.
Okay, thank you.
For the tubing, do I need to explain again?
It's clear. It's clear actually. So I'll move on to the next question, Sana.
Okay.
And is there any time frame for rebiopsy rebiopsying the embryo after warming?
Wait until a proper expansion of the embryo, like maybe 2 to 3 hours. If the embryo is quite nicely expanded, if you want to wait until some cells to be hatching, then wait a little more longer. If no, then after a proper expansion, you can just do this assisted hatching and then aspirate the cells and do the biopsy.
Okay, what is your preference? Do you breach the zona on day 3, or you like?
As a recommendation, we would not say to do the assisted hatching on day 3, because there are more chances of the embryo to be like early hatching, not well expanded, and it will start hatching. And there is also chance of ICM to be hatching from the part where you have done the zona drill. So it will make the biopsy more difficult. So try to go for a natural embryo expansion and as a natural hatching process. If it is not expanded well on day 5, wait until day 6 so that it will start hatching on its, like few cells are coming out of the zona naturally, and then you can perform the biopsy.
Okay, that's a good suggestion. Dr. Ved Prakash, he wants to know that what can be done if the tissue sticks to the petri dish during rinsing before loading?
You can use like with the denuding pipette, just try to put some media on it and try to remove it with the pressure if it can be done. Or also with the help of needle, like surgical needle, you can just touch a little from the bottom to separate the cell. It's a sterile technique.
Okay, and there are no chances of cells disintegrating if you're touching it with a surgical?
No, not directly the embryo, from the edges. Not directly the cells, just from the edge, try to separate it. Okay. Or with the denuding pipette itself, if you put little more pressure, it will be separated. And another thing is, this thing can happen when you are waiting too long for the tubing process after the biopsy. If it is done immediately, it will not be sticking to the bottom. It will only be done when you have waited too long and the media tends to like reduce, and then the cells start sticking to the bottom of the dish. So avoid waiting for a longer period of time post biopsy to do tubing.
Okay, got the message. Akash wants to know that, do you change the biopsy pipette and denupet with every embryo biopsied?
Denuding pipette should be changed for tubing. It should be changed per embryo, so as to avoid any DNA contamination. For each cell or each embryo, you should use a separate denuding pipette. Biopsy pipette you can use for maximum 2 to 3 embryos for biopsy. Have an extra washing drops in the dish. So once you have performed one biopsy, go wash the biopsy needle in the washing drop, aspirate some media release so as to remove any debris of cells that you have from the previous biopsy, and then proceed for the second embryo biopsy.
Okay, and Dr. Ved wants to know that what is the maximum laser shots you can give to cut the trophectoderm?
Maximum you can go up to 5 laser shots. Also the laser pulse will also matter. Don't go like above 500 or 600 for the laser shots, because the more the laser pulse, it will affect the embryo development. It will hit the media, it can cause a damage. So avoid using more laser.
Okay, and Sanket, he wants to know what is the time frame to store the biopsied cells?
Biopsied cells post tubing. Post tubing you can store in a deep freezer as per the requirement of the media. We are Igenomix kit. You have to keep. You can keep it for maximum weeks, like 1 to 2 weeks. You can keep it in the deep freezer after the tubing. It won't affect the cell until the shipment. If you want to do like multiple cycles of biopsies, like 1, 2, 3 in the coming weeks, and you want to ship it together, you can wait until 2 to 3 weeks. No, it won't affect the DNA.
At what temperature? -20 degrees?
-20 degree.
-20.
In a deep freezer, yeah.
Okay, and there is another question. Dr. Yuvraj, he wants to know, he wants you to highlight few points about the validation process before starting the PGT program. Maybe Dr. Rajni can take this. She'll be the right person, I think. Rajni, are you around?
Yeah, Dr. Sarpreet, I'm here. So what exactly?
He wants to know the, how you validate the lab and, how before starting the PGT, what all things have to be done.
Okay. So, Dr. Yuvraj, I think you are aware of that for validating any new lab, the first and the most important thing we ask for the PNDT license. That's the first requirement, the regulatory requirements. Once you have everything, the regulatory requirements and the biopsy checklist you receive for the availability of all the consumables you require doing the PGS PGD biopsy. So we will take that follow-up from you, that whether you have all these consumable in your lab. And if you have all those, we will give you a PGT protocol, lab validation protocol, which you have to follow, as Sana has already explained, that what tubing techniques you have to follow. So the same way the protocol is made, where it is described that what things you have to take into account for doing the tubing and the biopsy. And what important point is that we say for the lab validation, you use, if you are planning a trophectoderm biopsy, we need that you should have a minimum like 2 discarded embryo of a good quality embryos. And you can do multiple, we need minimum 5 biopsies from these embryos. And for each biopsy, you have to provide the respective blank. So if you are taking one biopsy, after that, blank is the leftover media which is there in the capillary tube after doing the tubing. You have to release this extra media in the very next respective tube of that embryo biopsy, and that will serve as a blank of that particular embryo biopsy. The same way, you have to do 4 more biopsies with 4 more blanks. So we say we need 5 minimum numbers, but in case you want a 6 and 7, you can provide 6 or 7 biopsies with their respective blanks. And we will provide you all the instructions for kit packaging and everything. And you have to pack the kit, and we will pick the sample from your place, and then we run these samples for looking for the contamination part, and also the biopsy skill, whether you have loaded the cell exactly in the sample tube, not into the blank tube. So this way we are checking the embryologist skill and also the lab contamination part. So along with the validation sample, we also ask 1 or 2 negative control, which are just that you need to keep these 2 tubes or 1 tube open during the whole procedure when you are doing this biopsy tubing procedure, so that this should let us know that there was no contamination in your lab environment where you were doing the biopsy.
I think that answers it comprehensively. Sana, somebody in the audience, they want to know which is the most preferred laser which you are using. Anything you'll recommend? I mean, with due respect to all the companies, unmute yourself, please.
Hamilton is a good option, like we are using Lycos, but there are also many, like from RI, the Saturn is also giving good results, and it is easy to use.
Another part of this question is, any preferred holding pipette, any preferred injection pipe? I mean,
holding pipette, holding pipette you can use with minimum diameter of 30 degree. That is, TPC is a good option. It's
okay.
a brand which you can use. And for biopsy needle, also 30 degree flat polished. There are some references. If you want, I can just let me see if I can share.
We'll share it with the audience. We'll share it.
There are some from Origio which can be used, and also for biopsy needle, you have to make sure like the size of the biopsy needle will be as the embryo expansion grade is more, the size of the biopsy needle will go smaller. Larger the size of expansion, the smaller the size of the biopsy needle you have to select. There are few references. If you want, I can just write you through an email or send, you can further communicate.
We'll share it with the audience. Yeah. Ashish wants to know, what is the technique used for analyzing aneuploidy status of embryo biopsy? Is it microarray, NGS, or?
NGS. For Igenomix, we are using NGS for the analysis because it is more sensitive and more better results.
And any recommended time frame to complete biopsy of the embryo?
It depends upon the practice of the embryologist, but you have to avoid more exposure of the embryo outside, like it's already day 5. Maybe within 10 minutes of time you can perform one embryo biopsy. If you're more experienced, you can perform within 5 minutes of time. Just avoid more exposure outside the incubator for the embryo, because, and also within a less time period of time, try to perform the biopsy.
The less the better, actually. There is no
Yeah.
recommended guideline as such.
Yeah.
And Akash wants to know time to store before tubing post biopsy.
Mostly we recommend doing it like once you have done the biopsy, if you are 2 people performing in the lab, do it parallel. One person is doing biopsy, immediately the other person is doing the tubing. If this is not possible, if you are selecting 2 or 3 embryos for biopsy, it will be like maybe you will take half an hour to finish these 3 embryos biopsy, and then you can proceed immediately for the tubing. Avoid, as I told, because if you are making the time more for the tubing, it will get stuck to the bottom or the media will start reducing. There are many chances of this also. If you know that it is going to take time for the tubing and you have prepared a dish prior for the tubing, you can overlay it with the cold oil, because tubing is to be performed on the cold surface. Overlay it with the cold oil so as to avoid evaporation of the media.
Okay, thank you. Ram Prakash, he wants to know how many embryos in a dish at a time while performing biopsy. I mean, how
Maximum,
many
I think 3 should be fine with the same needle if you are performing the biopsy.
and
Using the same needle, go for maximum 3. So as there is no more DNA contamination from one embryo to another.
Okay, and Daria, she wants to know what is the maximum term to store the biopsied cells in PCR tubes before PGT?
Yeah, as I mentioned before, like before the shipment, like if you are done the biopsy and you have done the tubing, you can store in your laboratory in deep freezer until like 2 to 3 weeks until you do the shipment. If you are waiting for other cases, otherwise we will recommend you as immediately, if you don't have any other cases coming up, and you can immediately ship it to the Igenomix so that the analysis is done and you can get the results. Like, because the more you store, it is going to take time for the results for the patient. It will affect like the time period. It will take more time for the to give the results to the patient after the biopsy. So avoid, I would say just 2 to 3 weeks will be fine. But it can be stored in the deep freezer for, like in the laboratory it is stored for a longer time.
Yeah, so Dr. Sarpreetji, I would like to add here that for storing, as this question has come 2 times, that storing the biopsy after doing the tubing, before sending the result, before sending the sample to Igenomix, we say that for PGT-A, there are patients where pooling is required. They pool 2 or 3 cycles also. Okay, so buffer has the buffer which we provide you, the loading buffer and washing buffer. It has a 6 months expiry. Okay, so we say that you can store the sample as per with that expiry and in -20. It will be not of any trouble to the sample, but the sample should be stored in -20.
6 months from the time we
So when you receive the kit from Igenomix, you receive the buffer solution, the buffer media. You have the expiry lot written over that. It says that what is the expiry. So there is a lot written. The lot says the day it is manufactured. So the day of expiry is 6 months later to that.
Okay, wonderful. There are no more questions. Actually, Sana, I must congratulate you. Most of the questions you answered during your presentation. And now I will hand over the screen to the coordinator of the webinar, Sanket. Okay.
Sanket sir, please start your video.
Sanket, there is another question. We'll
Yes,
take
sir.
it also,
Please,
since we
please,
have
sir.
time.
Please, you can take, sir.
Yeah, Ashish is asking, can DNA extraction be done by IVF lab? Will this reduce the turnaround time to get the results?
We don't recommend, like, this is the DNA extraction will be done in the Igenomix laboratory. If the lab is well equipped, I don't know what protocol they will be following, but for Igenomix we are following a particular steps or require a protocol once the sample is received. So we won't recommend like DNA extraction in the IVF laboratory. The steps to be followed are like, to have the results, a particular protocol is to be followed.
Dr. Rajni, would you like to add something?
Yes,
Dr.
yes.
Rajni, comment on this.
Yes. So, Dr. Ashish, I think you are asking that DNA extraction from the biopsy sample, right? That is not possible because, see, the PGS protocol is one single protocol, and that whole protocol goes in the same tube in which the tubing has been done. So it follows a WGA process. Whole genome amplification is the first step, means we have to receive the Trophectoderm biopsy, and then those cells need to be amplified for getting the better amount of DNA. And then we follow the library preparation and then NGS. So this cannot be done that we do DNA extraction first and then you send the sample, because this is one single manufacturing protocol we have to follow. So we cannot differentiate from that.
I think Ashish, the message is quite clear now. Another question Ram is asking, would you recommend, do you recommend preloaded tubes, or the embryologist should load the buffer in PCR tubes before biopsy?
Here in Middle East or India, we are providing the PCR tubes pre-filled with the unique media, which is like appropriate volume is loaded. We are making sure like the media is to the bottom of the tube and there is no issue when embryologist is performing the tubing. Embryologists can also be getting trained and they can perform. There are some clinics who prefer to do loading themselves, the PCR tubes, but then they should be trained properly. They should know like how it is supposed to be done, how much volume is to be taken, what precautions are to be taken. If they are well trained in this and they are confident enough and the validations results are good, they can perform the loading of the tubes as well.
Okay, there is another question. Ankita Sethi is asking, this is for Dr. Carmen, single step media versus sequential step media in PGT A. Which is better and why?
Anyone can work. You can use sequential media or you can use single step media. No problem at all. In our protocol, there is a step in the middle of embryo development that we add to have extra washes of the embryos. And this part of the protocol is on day 4, early in the morning on day 4. So if you are using single step media, it's okay. You just grow the embryos regularly. On day 4, you have to do extra washes and move to a new dish that is a special dish with a smaller drop. If you are using sequential media, it's okay too. You can change the media on day 3 and then do the extra washes on day 4, or you directly can do the change of the media early in the morning on day 4. So both medias can be adapted to the protocol.
But in sequential, when after changing the embryos on day 3, we again give them a wash on day 4? I mean,
this is what we recommend, but what many people is doing is to change early in the morning on day 4. Instead of changing the embryos on day 3, to delay a little and to change on day 4. Another possibility is that we require these extra washes on day 4, but we accept if the extra washes are performed in the afternoon of day 3, and then you change to the sequential media. So we can adapt the protocol in these 2 ways for the sequential media.
So you want to get rid of the day 3 DNA and all. The extra washes are meant for diluting the day 3 DNA, and you want to, because we are focusing on day 5 and day 6 DNA. I mean.
Exactly. We want to dilute the DNA that is in the media from previous days. The most tricky thing is to have still media from the cumulus cells, because even you cannot see them, maybe they are diluted and suspended in the media. It's also quite frequent to have DNA from the polar body, because we have observed the complementary chromosomal aneuploidy. So you can have also DNA from the polar body. And also if there is one or some cells that are fragmented during these early stages, this DNA. So I think it's good to try to remove, but mainly the aim of these extra washes steps is to remove any remain of DNA from the cumulus cells. The cumulus cells are our nightmare here. We have to try to avoid them.
So over to you, Sanket. I think we're done with most of the questions.
Yes, sir.
Thank
you so much.
There is 2-3 more questions, I think.
Yeah, so there's some more questions.
Yeah. From
Sir,
Shubhangi.
sir, can you please take those questions?
Giridharan is asking, How to store and ship sample for CFPGT? Temperature and duration, stability, is it possible for days or weeks, similar to the cells collected by invasive protocol? And he's just comparing the shipping process in non-invasive PGT versus invasive PGT.
Okay, it's very similar. So if you are already working with us for PGT-A, it's exactly the same. When you collect the media, you freeze the media and you store in the freezer, and you can store for 1, 2, 3 weeks as for the Trophectoderm biopsy. So it's the same. And once you are getting ready to prepare the shipment, you will receive the box and you will place the tubes in the same cool rack. So the process for shipment of the non-invasive is very, very similar to the invasive, to the regular PGT-A.
Okay. Thank you, Carmen. I think that answers most of the questions. There's another question which has come from Dr. Sanjay. He's asking, do you still prefer to perform the genetic testing on ICSI embryos, or conventional embryos can also be used? Conventional IVF embryos can also be used.
Okay, I think the question is in general for PGT-A and non-invasive PGT-A, I guess.
You can answer it in both. I mean,
both.
does IVF embryos work? I mean,
yeah, IVF embryos work, but they work if you are going to do a chromosomal analysis. So before you start to work with a genetic lab, you have to ask if you can use IVF, because IVF can be used depending in the amplification protocol that you are using in the genetic lab. So if we are using NGS, for example, for our PGT-A, PGT-A-SR, and the invasive, for the 3 protocols that we are using NGS, you can do regular IVF. But if you do regular IVF, you have to denude, to accumulate very well the oocytes when you check for fertilization, very, 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 very well. Because the sperm is not the problem for the results of PGT-A or non-invasive. The problem is the granulosa cells. Granulosa cells, cumulus cells, are a risk for the non-invasive, but also for the invasive. Because if you are doing the Trophectoderm biopsy and you have some cumulus cells attached to the zona, close to the area in which you are pulling the cells, then you can have also contamination. So IVF can be performed as far as you accumulate properly the zygote, as in an ICSI cycle, after fertilization, when you are doing the fertilization. And one very, very, very important question, if you are doing PGT for monogenic diseases, this is completely different. So please, please, please don't do IVF for monogenic diseases, because we are not applying NGS. We are applying special PCR protocols. And in these protocols, sperm can be amplified. In the whole genome amplification protocols, the sperm is not amplifying. And we have done several tests in our Dubai lab, and we know that. But for monogenics, no IVF, please. This is the important thing.
so Carmen, since you're also an embryologist, at times cumulus is stuck to the embryo and it cannot be detached, even in IVF cases especially, go on denuding and the cumulus fragment will not go off. So do you recommend any particular technique to detach the cumulus? Because if the embryo is going to go for PGT, then we need to get rid of the cumulus.
Well, I think, for example, when we are doing the non-invasive, we recommend the people to decumulate properly before ICSI, or if it is IVF, after IVF. One recommendation that we are giving in general is that when you are doing the decumulation for ICSI, if there is some cell remaining attached to the zona, the day after, when you are checking for fertilization, sometimes it's easier to remove the cells. So don't stress too much the oocytes the day of womb pickup. No need to stress too much the oocytes at this point. If there is 1 or 2 cells still attached to the zona, try to remove them the day after, because at the day of fertilization, usually they are looser and they are easy to detach. And even though if it is for a PGT-A case, before doing the biopsy, try to wash the embryo to remove if there is any cell. In the case of the non-invasive, because we do these extra washes on day 4, if there is still any cell remaining, you can try to wash and they should disappear. So the idea is to try to remove as many as you can the day of the ovum pickup, but if not, do not stress too much, try to remove sometime later.
Okay, I think we'll end with the last question from Akash. He's asking, can non-invasive PGT be used for monogenic disorders?
Not now, not for translocations, not now, but I think in the future would be. Maybe not for every monogenic disease, but at least for some of them in which we know that the carrier is the husband, and if there is contamination from the cumulus cells, we are going to be able to identify, but not now. Now it's just for aneuploidy and in this kind of prioritization system, because we want to be sure that we are not risking too much, and we have now a clear knowledge of the advantages for PGT-A. For monogenic diseases, we will need to have maybe more automated systems to denudate the oocytes and all these things, because for monogenic diseases, we will need a concordance of 100%. So we should wait a little more.
Okay.
Yeah, there is one more question to Dr. Carmen by Dr. Shubhangi. So how close are we with respect to CRISPR gene editing in human embryos? Is it worth?
Can you repeat again the question? Sorry.
Yeah, how close are we with respect to CRISPR gene editing in human embryos?
Okay, well, this is difficult to answer because I think it's a question of opinion. We know that the technology has evolved a lot, and we have discussed a lot internally with Professor Carlos Simon. How can we foresee the CRISPR applied with the new publications that we have seen, even to correct aneuploidy? And the problem is that what should you do? If you are doing for monogenic diseases, you should do the biopsy of the polar bodies to know which embryo has the mutation. Then when you have to inject, if you inject in the oocyte, the efficiency is higher. If you inject in a two cells embryo, then you have the problem of mosaicism because the distribution of the correction. And also it has been seen that when you are editing, sometimes you have the edited part in a different part of an undesired part of the genome. So it's not so, the last publications, they saw that this is encouraged, this is very good, but I think that it's not ready for clinical application, and the application, the only benefit would be for these diseases in which you are sure that all the embryos are going to be abnormal. But for dominant disorders, recessive disorders, you have still a good probability of having healthy embryos. So I think that the only clinical condition that can benefit from this are these diseases that you know that all the embryos are abnormal. And in these cases, I think that still is too risky. But this is personal opinion. I'm not working in this field.
Yeah. So one last question. So would you recommend us the necessary steps in order to reduce the maternal DNA contamination when you're going for NIPGT?
Yes, sure. For non-invasive PGT-A, we have to minimize the risk of contamination, because if we have just a single cumulus cell in the media, it's going to give us a result of female normal. So we don't want to have even a single cumulus cell in the media, because then it's going to be very risky. And it's not so strict with PGT-A, but it's also very important to be careful with cumulus cells for PGT-A, as I mentioned, because we have seen sometimes that there can be a misdiagnosis in PGT-A if there are cells of the cumulus cells very close to the biopsy area.
Even Dr. Sanjay sir was also asking, in case of IVF embryos, are there a chance of sperm DNA contamination?
If we have sperm DNA contamination, it's not a problem for us. If we are using NGS, because the nucleus of the sperm is very packed, it's completely packed. And the enzymes that we use to the NGS, they cannot go inside the packed sperm nuclei. we will need to do special treatments to decondense the DNA of the sperm to be able to apply the whole genome amplification protocols that we apply to trophectoderm biopsies. And this is the reason we can have an sperm in the tube, but the truth is that it's not going to amplify because the sperm DNA is compacted in a different way and it's very packed. And the enzymes cannot go in and it's not amplifying. And we have done the test with 30 sperm per tube, 15 sperm per tube, no amplification at all. And it's not only us. We were reassured by the group of in UK. They presented also an abstract 2 years ago in the PGT-A meeting in which they were doing also the same experiments, different dilutions of sperm, trying to apply the protocol of the biopsies, and it's not working. If the mature sperm, the only thing that can be amplified for NGS if you have spermatocytes, or because in mature cells of the male germline, they can react because they are bigger and the DNA is not compacted in the same way. But mature sperm, they should not react. Mm-hmm.
Yeah. Thank you so much, ma'am, for answering all the questions. And I would like to thank Dr. Sabir sir and Dr. Sana and Dr. Rajni for answering all the questions. And I would like to hand over to Dr. Ved sir. Ved sir?
So at the end, I would like to thanks all the panelists, Dr. Carmen, Dr. Sana, Dr. Rajni, and Dr. Srapri, Dr. Pranay Ghosh, and is Dr. Jayant Mehta is there?
Yes, sir, he's here. He's here.
Yeah.
Jayant, sir, you can please unmute yourself and start your video.
Hi, I'm here. I'm here.
Yeah, sir. Any final comments you want to give, sir?
No, I think it was a very excellent presentation by Carmen and Sana. They have highlighted what we should do and what we shouldn't be doing in the lab, and not to actually think that this is an easy process. It requires a lot of careful thinking, and also we need to understand what we are doing. And I feel that the learning curve is much steeper than what we may imagine. But I personally feel that we have the technology at hand, and we should be very, very careful how we use it. And we have a lot of advantages and disadvantages. And I feel that with workshops like this and with their help, we should all be able to learn more. Thank you very much.
So thanks to Emcure and Igenomix, and special thanks to Mr. Vikram Ganju for making this success and supports. So thank you very much, and we will meet again in mid-December for next webinar. Thank you. Thanks to everyone. Thank you so much.
Thank you, sir.
Thank you.
So from Emcure and my senior, Mr. Rajiv Agarwal, General Manager, Sales and Marketing for iHERA, I thank you, sir, Ved Prakash sir, for always being giving us an opportunity. Thank you, Dr. Carmen and Dr. Sana ma'am, for being there, and it was a great session because both of you were there. As always, thank you, Akash sir. Rajni ma'am, thank you for being there. Pranay sir, it has been nice to see you. Sarabjit sir, thank you to you as well. So thank you, and we'll continue such academic initiatives. We are a phone call away.
Thank you. Thank you so much.
Thank you, everyone.
Thank you.
Thank you very much, Dr. Ved. Thank you so much.
Thank you.
Thank you so much.
Bye-bye.
Bye-bye.
Bye-bye. Everybody, bye-bye. In the meantime, I'll be playing a 2 minutes video of Emcure, and then I'll be closing the session. Thank you all for being there.
Thank you.
Thank you.
Thank you, Sarabpreet sir, for being there. Ved Prakash sir, thank you for being there.
Thank you.
This was just an announcement that we are coming up with an mRNA vaccine for COVID, which is already in second phase, and rest of the corporate video. So thank you from our team to you. Thank you, Pranay sir, for being there. Now we can actually close the session.
Thank you.
Thank you, sir. The recording will be available in 48 hours on IVF Virtual Academy, the YouTube channel, which I'll share with Ved Prakash sir.
शेयर करिएगा, डायरेक्ट मुझे शेयर कर दीजिएगा.
जरूर 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 sir. Thank you, sir.
Bye bye.
Bye, sir. Bye.
Bye bye.